All right, well, good afternoon, everyone, and welcome to today's webinar. It's a MyPost Advisory Committee to MDHHS and recommendations. We're so glad that you could join us as we continue to learn about the important work here happening around Michigan's physician orders for scope of treatment. We're especially excited to have two wonderful speakers with us today. Amy Bailey, she's an advanced care planning specialist and ethics coordinator with My Michigan Health, and Rose Seavolt, who is an advanced care planning consultant and educator. They'll be sharing their knowledge and experience to help us better understand the committee's recommendations and how these can support patients, families, and care teams across Michigan. If you weren't able to join us for the first session, please don't worry. You can find that recording on Michigan Center for Rural Health's website. We'll be sure to drop that link in the chat here so that you can catch up on that at any time. So I just want to thank you for spending your time with us today. We're looking forward to an engaging and informative session. Rose and Amy, it is all yours.
All right. Thank you, Amanda. I appreciate that. So let me just give you a brief introduction of a little bit about more of who I am and why I'm interested in this work. I have worked across the lifespan of individuals from neonatal ICU to geriatrics. I've done a level 1 trauma center. So this has become very important work to me. Both Amy and I have seen the good, the bad, the ugly of these kind of documents and how they play out. So today we hope to go through some of this today to help you understand a little more about the MyPost. We're going to encourage you to ask questions in the moment. You feel free to unmute yourselves, or you can enter a question in chat. We find it's easier to address your questions during the moment, so please feel free to do that. Both Amy and I will pause to give you time to ask a question should you have one going through your mind. The other thing as we go through this, I'd like you to consider what is the current use of the MyPost in your community? And then how, as we go through this today, how can you increase the use of that and make it more effective? So this is actually the MyPost document as it stands right now, and it's divided into different areas. So the first part, the part 1, is really just whose document is this? So the patient's name goes there, that type of thing, their date of birth, those important things that we need to know about that individual. This is a physician order. So the second part is how much care do they want? So this helps to define in section A whether or not they want CPR. But the MyPost conveys much more information to the healthcare teams and EMS than just their CPR status. So it includes, you'll see in section B, how much care do they want? Do they want comfort-focused treatment, selective treatment, which is more, but maybe not everything. And then your full treatment is where they would like everything done, including CPR. They may want to go on ventilators, those types of things. Section C is for any additional orders. They can specify on here. So take, for instance, someone who says, I don't want to have CPR performed on me, but I have COPD, and if I have an exacerbation, I would definitely want to try the ventilator again. So even though we can declare those things in section B, it's easier to put something that specific in section C. It also can declare things like feeding tubes, that type of thing, whatever they would want or not want can be put in there. This document is customizable to the individual's preferences for how much care they want or don't want. If you look to the right of the screen, section D, this is the back of the form. And this is just the signatures that need to be put in place. So the signature of the attending health professional. If you can see that on the third line down, it's print name of collaborating physician. So for the MyPost, your advanced practice practitioners can create one of these MyPost documents as well as the attending physicians. So that's why that is on there. Then you'll have the section E, which is the signature of the patient or patient representative, just stating that this is a document that they are creating. Underneath that, information of legally authorized representative. Again, that would be if it was signed by the patient advocate or a court-appointed guardian. So that's the portion that would be done there. Section F is if I'm doing it as a facilitator, I'm helping to create this form, but then they take it back to their providers to have the signatures done. I would put in my information there. Section G is the reaffirmation or revoking of that form. And then those again, just so the back page really is just a bunch of signatures that convey who's done what in the creation of this document. And they will put, Amanda will put the link. You will be able to find this document on your Michigan Center for Rural Health website page. And so she will put that link to that on your webpage. So in addition to creating the document, it's very important that we have that discussion with the patient. So this is a document that was created by the legislation so that the patient and the physician talk about this MyPost form during the creation of it. And so this just says that the physician has gone over those important details with the patient, and the patient signs or the representative and then the signature. We did question as we went through the process of utilizing this document, if this form did not accompany the MyPost, would it negate the ability to use the MyPost? And the answer is no. So yes, we want that done. We want it signed. We want it to be a part of their medical record, but it would not negate it if we can't find it at the time that we need to have it. So the other thing I always want to point out is the MyPost is a physician order. It's still very important for your patients to designate who they assign as their patient advocate. That is the durable power of attorney for healthcare. That individual who can legally speak for that person if they can't speak for themselves. So even though they may have this document, it still is important to make sure that they have their patient advocate document signed and executable. Questions on any of that before I go forward? So this is really just kind of a information slide. The MyPost website has copies of the medical order that I just showed you, the MyPost, and that patient and family information sheet. They are available in 3 different languages, English, Spanish, and Arabic. You'll find the final report on the MyPost on their website as well. And this email is if you have questions or you want additional training, would be where you would email to request that. So I'm going to, at this point, hand this over to Amy to continue, and she's going to share a little bit about the history and give an example of the MyPost in action. Amy?
Thank you, Rose. So glad to have all of you here joining us on this conversation regarding the MyPost. I'd like to point out that Michigan was not one of the first states that embraced the MyPost. Actually, we're a little bit behind the game, but that's okay. So our law came into effect in 2017 to create the MyPost. There was a little bit of a delay to get it out to all of our counties. One of the reasons was there was a lot of public comment that they wanted to address. There were some special interest groups that expressed their opinions, and so further discussion was held. And then also COVID happened. But back in 2022, MDHHS convened an advisory committee to set in place the MyPost form, the patient and family information sheet. We gathered to create endorsed educational materials for specific user groups, whether you're a clinician in the hospital or you're working in home care or in skilled nursing. There's a frequently asked questions document, as well as the email that Rose just mentioned about requesting additional training or asking questions. And then our group began educational outreach regarding the MyPost form. And so Rose and I were part of the advisory committee. Some other folks that joined us were some of our larger health systems. We have representation from home care, skilled nursing facilities. We had Lara there. We had EMS there. And it was a pretty diverse group that came together to create the training and help with finalization of the form. And what we encourage for those who have joined us today is it's really important to reach out to your medical control authorities and engage in conversations with them about the use of MyPost. As was stated in the part one of this training, the MyPost guides care for emergency medical services only. That's what the law states. And so I think and we'll address that a little bit further, but we do really encourage you to reach out to your EMS partners for conversations about MyPost. EMS did get thorough training on the MyPost, but we recognize that there are some areas of EMS where maybe it's a largely volunteer organization. And so just making sure that everybody's on the same page about MyPost is really important. Another thing that we shared is we shared with other aspects of our state legislature and state government about the MyPost. There's the Health Information Technology Commission, or HIC Commission. And so we provided some testimony there and regarding the final report. And so Rose and I will be going over those recommendations about the final report. But to get us a little bit more, give us a little bit more understanding about the MyPost, we'd like to offer this scenario. So here we have a patient. His name is Edward. You might have run into this patient before. So Edward has created a MyPost. His primary care health provider is his nurse practitioner, and Edward lives at home with his spouse. His MyPost is posted on the refrigerator as recommended by EMS, and he experiences shortness of breath, and EMS is called. When EMS arrives, Edward is non-responsive and he has no pulse. EMS professionals are unable to determine if the diagnosis of CHS, which is what was listed on his MyPost, was the reason why he had this event. And so due to that uncertainty, they decide that CPR is initiated. For Edward, just to give a little background about his MyPost, he chose that he did not want to receive CPR on his MyPost. But due to the confusion around the diagnosis and whether or not that contributed to this event, EMS decided to give him CPR. And so Edward was transferred to the emergency department, where he continued to receive different types of care that did not appear to be in line with his wishes as were described on the MyPost. So we really like to recognize here that the MyPost in its current state doesn't appear to be structured to support the realities of end of life care. And Edward's scenario is an example of this. So that's what led us to create our final report in hopes that we can share some improvements to the MyPost. Any questions on that, on our scenario? All right. So let's dive into those recommendations. Some of the folks on this call might be well aware of what I'm about to state with this first recommendation, but for some of you, this might be new. Michigan does not have a next of kin law regarding making medical decisions for another adult. I think that we are on our 7th attempt as a state to pass that type of legislation. Currently being considered, we have a House Bill 4418 and 4419 for anyone who's interested in diving into that proposed bill. I'd also like to recognize that Michigan is right in line with national averages, in that 30% of US adults and Michigan adults have completed patient advocate designation. One of the things that I do in my role here at My Michigan Health is I track our hospitalized patients. And on a good day, we might have 25% of those patients have a legal document that names a patient advocate. So the majority of the individuals that you are going to encounter do not have a legal document that names their patient advocate. And this next of kin law places a lot of hardships on patients, on health systems, on their loved ones. It causes problems with discharge planning from the hospital at times. It puts people at risk of needing a legal guardian. And also of note, I think Michigan is probably third in the nation as far as numbers of legal guardianships. We have a lot of legal guardianships. So whether or not this current proposed bill will fix any of those things or actually get passed, because again, it's our 7th time. I think right now I wouldn't be doing my job if I didn't share with everyone the great importance of creating a patient advocate designation or durable power of attorney for healthcare. That's two different titles for the same thing. So really encouraging that work in this space. Another recommendation that we shared in our final report is to allow electronic signatures for advanced care planning documents, which would include the MyPost and out-of-hospital do not resuscitate order and the durable power of attorney for healthcare or patient advocate designation. For a brief period of time during COVID, electronic witnessing was included, and we did have the ability to do that, but that emergency order has since expired. And although you'll see when you go on the website that you can type in certain aspects of the MyPost, it still requires a true signature, meaning pen and paper. And so that is another recommendation that our committee shared with as part of the final report and as we're educating others. Some other folks that we've reached out regarding education include our long-term care ombudsman. I know that David Donahue with Laura has provided education to skilled nursing facility state surveyors and others in the skilled nursing facility space. So we're trying to get the word out, but we certainly appreciate any feedback that you guys have and also your efforts in helping us make this a better order and service to our adults with advanced illness and frailty. Any questions before I hand this back to Rose? Okay.
Thank you, Amy. So continuing on with some of the recommendations, as we've used the form and had experience with its effectiveness as well as the barriers, these were some additional recommendations that we are bringing forward. On the form, the MyPost, there is a 12-month expiration date, and that we want that aligns. We want to remove that to align with the out-of-hospital do not resuscitate order. So the out-of-hospital do not resuscitate order does not have an expiration date. The MyPost does. So think about this: if they don't create another MyPost before the end of that 12-month period, then their MyPost would not be considered executable, would not be a current order. So that is a problem. The other thing that we know is that we don't have a crystal ball to know exactly when someone's life is going to end. These are things we just take into consideration. So it's important to think about making sure that the people that have done these documents ahead before these new laws came into effect, we would not be able to honor those documents if they are not currently consistent with the laws. So it's important that we take that 12-month barrier off. Part of the other reason is what we do know is when people have a serious illness, chronic illness that it increases or goes down the trajectory, chronic illnesses, serious illnesses do not improve. So what happens, what we find many times, not always, but majority of the time, that as the trajectory of their disease worsens, that they get to a point where they just choose less and less care. They don't want the burden of extra visits. They don't want people doing more things to them. So it's really not about the lifespan time. It's about where they're at in their trajectory of their illness and how they feel about it. How much do they want to continue receiving? What care do they want? What care do they not want? And so that is another reason that we feel like this is a barrier to making sure that they will receive the care that they want and not receive care they don't want, which is an example that Amy just gave you in that Edward scenario. So that's really important that we know that. We do know that some health systems have EMRs that display an individual's end of life index and potentially the advanced care planning documents. But we also know that when that patient leaves that system to a new facility, those forms don't always travel with the individual. So that becomes problematic as well. So there's gaps in the healthcare continuum. The other thing we want to think about is to remove the reaffirmation and requirements of the MyPost to align again with the out of hospital do not resuscitate order. So there is no reaffirmation for the out of hospital do not resuscitate order. And they put that in for the MyPost for the reasons I already mentioned, because then we have that whole 12-month expiration date. We have to create another document. And really, again, it boils down to where they are in their trajectory of their illness, how much they want, how much they don't want, so that we can continue to honor their wishes over the trajectory of their illness. And they're not worrying about creating another form. They're not having to worry about the calendar ticking away. What do I need to do now? So it's important that we take those barriers away so that we can honor their wishes. So one of the other things that we want to do is to remove the diagnosis supporting that MyPost form. And again, the scenario that Amy went through with Edward was a perfect example of why this is a problem. So having an associated diagnosis again on that document really can delay care or create care being given that they don't want. So think about this. I'm EMS. I'm going to a scene. I've been called to a scene. Someone their heart has stopped, and now I'm placed the burden of trying to figure out if their demise or their event occurred because of their diagnosis on that MyPost form. I've worked in a level 1 trauma center for way too long, and I can tell you, even I wouldn't know that. So taking that off, again, it's not relative to a diagnosis, it's relative to where they're at in that trajectory of their illness and how much they want or don't want. So taking that off would really eliminate that barrier and prevent people from receiving care that they don't want. So that's really the rationale behind that recommendation. The other thing that we're recommending is that the MyPost expand to direct care outside of just EMS personnel. So like Amy mentioned, current law is that it's for EMS personnel. It's important that all clinical teams have the ability to use that document when a patient is transferred to them. So here's some examples. So think about you have your Medicare wellness visits. Those appointments happen in an ambulatory care setting. Sometimes things happen there too. Very well aware of it. Sometimes patients will have events where their heart stops in an ambulatory setting. Think about urgent care. Same thing there. People will go to an urgent care because they're afraid to go to an ER. They have a heart attack there, and that document does not apply to even an urgent care. Another example, and I've had calls from nursing home administrators before regarding this other scenario. When a patient is transferred to a SNF, we want that document, that MyPost, to be effective there. So what happens is by law, they have to have a new document or a new order written on their chart in order for them to be honored if they don't want CPR. The problem is I had a nursing administrator call me and she was like, you know what? We know this patient didn't want CPR. They came, but before our physician could write orders on that chart, they had a heart attack and we were forced basically to go ahead and do CPR. And she was very distraught. And she's like, did we do the right thing? And I said to her this, by law, you did the right thing. For our patient, no, we didn't do the right thing. So you can see the disconnect that occurs when these barriers are applied to this document. So that is really the reason that we want that document to expand beyond just EMS. Questions on that before we move forward? Okay, thank you. So a couple other things that we really are thinking about is removing the witnessing requirements for that out of hospital do not resuscitate order to be consistent with the requirements for the MyPost order. Again, these two documents are medical orders. Even though we consider them advanced care planning documents because they do convey the type of care someone wants or doesn't want, they are medical orders, which sets them in a different pocket. So medical orders in general do not require witness signatures. So part of the challenge to this, if I'm in the community doing an advanced care planning conversation, which this is in reality, I have encountered this, and somebody wants to have that out of hospital do not resuscitate order created, then I have to find some witnesses. So many times these people are frail, they don't have a lot of family nearby, maybe they do, maybe they don't. So sometimes we'll try to get a neighbor to come be a witness. So again, it requires extra care coordination to try to get these documents in place. It also can create a time frame where once we know they may not want CPR, but because we can't get all the signatures in place in a timely manner, that they then have an event and then they receive care they don't want. So again, we really need to be cognizant of the fact that these are medical orders. So that is the real rationale for why we don't want that to be in place. The second one here is to allow the advanced practice providers the authority to sign for an out-of-hospital do not resuscitate order. So current status is the out-of-hospital do not resuscitate order can only be signed by physicians. The MyPost, on the other hand, can be signed by the APPs as well as physicians. Just having these two documents and the different requirements for both of them is confusing to the healthcare team. Physicians are confused by it, providers are confused. Those of us that, have to use these documents can be confused. So that's part of it as well, is the end of care life should be no different. Think about many times now our advanced practice providers can now operate independent of a physician, especially in rural areas. So if they're not allowed to sign these documents, their patients would not receive the care they want or don't want. So again, thinking about how we provide care across the continuum of someone's life is very important to keep it consistent. So that's the rationale for that recommendation as well. So I'd like to give you another, if you go ahead, yeah, thanks. I'd like to give you another scenario. So this is John. And John is a 67-year-old gentleman with a glioblastoma. That is a brain tumor. He lives with his wife, Sally. John is experiencing intermittent seizures, which have been worsening over time. He completed a MyPost with his neurologist at a recent office visit. So John chose not to be resuscitated. Sally and John's adult children assist with the care of John intermittently to give Sally a break. They are all aware of John's wishes to forego resuscitation if his heart stops and to receive comfort care up until his passing. So John's decisions now are written in a medical order that serves to avoid unnecessary hospitalizations and aggressive medical interventions that he believes would only cause more pain and suffering. He realizes his diagnosis is terminal, and so he decided if he had a cardiac event before the cause of the glioblastoma caused his death, he was okay with not being resuscitated. So what happens in practice then, go ahead and forward that slide, Amy. Yeah. So then last Saturday, for an example, last Saturday afternoon, John became combative and went into status epilepticus, which is just continual seizures. Sally found her phone and called 911, and she stated, "This is not an emergency. My loved one has died. They did not want to receive CPR, and we have a MyPost order confirming this." That allows dispatch to know how to handle that 911 call. So this is something that we teach to our patients when they have this kind of situation. So prior to John's arrival, or to the arrival, John's heart stopped. When the paramedics arrived, Sally described the event to the paramedics. She informed them of the glioblastoma and its complications and showed them the MyPost. EMS notified the medical examiner, who then spoke with John's doctor. The neurologist confirmed the cause of death was not in question, and ultimately his wishes were honored as it was written on the MyPost. This is an ideal situation. This is not current practice. This is ideally how it should work. So EMS many times is asked to be the medical examiner inspector. So previously we used to tell people not to call 911, but to call the local number. But now, because of that change where the medical examiner or EMS can be the medical examiner inspector, we do have them call the 911 number, but to start out again stating this is not an emergency and then going on to describe what's happening. That is the best way to really handle those kinds of situations in practice. Again, I just want to point out that's ideal. It is not common practice right now. That's what we're aiming for. All right, I'll turn it back over to Amy unless you have some questions for me on any of that.
Does anybody have any thoughts about John's scenario? Or have you encountered a similar scenario in your work?
Feel free to put any comments or ideas in the chat or unmute yourself.
How many of you have how each system views their emergency department? So in reality, an ER is an outpatient setting, so that MyPost would not be relevant to them. What it is it's a communication tool.
Yeah.
So again, depending on the physicians, having worked with many different ones, they usually will honor something like that that's written and that we know about. However, the other thing that exists is when someone is transported by EMS to like an ER, a lot of times those documents do not accompany them to exactly Heather what you were saying. So one of the other things that we suggest, and when I train teams, I talk to them about that out of hospital do not resuscitate bracelet. However, the law is only relevant, that is relevant to the out of hospital do not resuscitate order and not the MyPost. So we have inconsistencies throughout everywhere, which makes it really hard. And it becomes very dependent on the physician, whether or not they want to honor that communication tool or not. Most of the time, they will try to make sure they get a hold of that loved one or their agent if they know who that is. And if there is a document, the majority tend to honor that, but not all. And Heather, to the point you made, we are seeing more and more, and Amy can attest to this, we're seeing more and more pushback from our community members when they receive care that they don't want, when they have created these documents. So, again, that burden lies upon us to figure out that system to make sure that we can honor those wishes when they present themselves.
Yes. Yeah. And it's difficult too when, you have so many different, organizations,
Yes.
working together to collaborate,
Mm-hmm.
but then you're all on different systems. And, yes, we're trying to integrate these systems and some work together great and some don't. And depending on, say, what your EMR is and, and maybe it's scanned into somebody's system, but not the other. And even within my own, it's sometimes difficult to find where a document is scanned in or not. And is it, like you said, does it expire within a year? Does it not? All of these things. And then, and I very much appreciate our attorneys, but sometimes the legal, the legal mumbo jumbo gets so tangled up, and you know, in our situation, the the community member was trying to commit suicide, and they were very angry that
Oh, wow.
their life was saved. And so there's just so many nuances
Mm-hmm.
involved in this. And you know, if there could just be one form, just one standard form that was universal, it'd be amazing.
Yeah, I really
Thank you.
appreciate that
Thank you.
input and
Yeah.
feedback, because it is true. It's very confusing for not only the patients and their advocates, but it's confusing to the healthcare teams, providers, everyone. What's active, what's not? Is it going to be executable? Is it not? You know, so that's part of why we've come together as a task force to create these recommendations based on the usage of the MyPost and the current legislation, knowing that it still is not, it's not effective. It does not prevent people from receiving care that they don't want, or make sure they receive care they do want.
Mm-hmm.
Yeah.
Absolutely. And
Great.
Heather, did you have something else? I saw you unmuted.
I just wanted to thank you both for your great work, and you know, fighting the good fight for the betterment of all. Thank you. It is so appreciated.
And Heather, you brought up a good point that I think all of us really can think about. As you said, the patient was basically suicidal, right?
Yeah.
And they did not want to be resuscitated. And in our society currently, we don't recognize mental health for what it truly is.
Right.
Mm-hmm.
And so I think that is problematic. And depending on the form that you use for the DPOH designation, your patient advocate designation, there has to be certain things in writing for the advocate to address mental health issues. So that's another thing that you need to be aware of. So I don't know, I don't believe, and correct me if any of you use the 5 wishes. I'm not sure about that. I know that the Making Choices Michigan Advanced Directive that was created with a huge input from community attorneys, you name it, does have the mental health page. And there's also all of the legal verbiage on it that is required if that agent can decide to forego treatment or withhold treatment that might cause a death. So it's really important to understand the different documents, their usage, what has to be present in order for us to be able to follow them, to what degree. So I hope that helps make sense that we really need to understand the documents, and that's why we're going over this. Today's really the focus on the MyPost, but just to give you that additional information on how to make sure the other documents that support and allow someone to speak for someone when they can't speak for themselves is really important to have in place.
Absolutely. And I think that we shared, correct me if I'm wrong, but we might have shared the Making Choices Michigan form with Aaliyah and Amanda, did we?
Yes. Yeah.
Okay.
So all of the wonderful documents that Rose and Emily talked about, also the Making Choices Michigan documents, will be up on our website by the end of the week, along with the recording from this session and the one from last time. And then all of our other palliative care focused items are also on our websites via that link that I put into the chat right at the beginning.
Perfect. Aaliyah,
Thank you
did
so
we
much.
also send you so along with that MyPost, there is an information sheet that Nikki Lewis, who is a social worker, she did a lot of mental health work. Did I send you that?
If you want to send it over to me,
Okay. So the reason I asked that for all of you on the call is Nikki put together how to address that whole mental health section on that advanced directive. So it's really like a transition statement. Many people are sensitive about mental health, but it's saying, you know, you told us a lot about your physical health and what you might want or not want. Let's talk about what could happen if you have a mental health crisis or a situation where you're unable to be clear-headed to tell us what you would want. And so then she tells you all the different treatment options in that portion, how to address them, what they mean, and that is very helpful. There are certain treatment options in that section that require explicit permission from that patient. So understanding how to maneuver through that section of your advanced directive is really important. And should you have questions, I'm sure Amy or I would be happy to help any of you if you have questions on that. but I'll send that to you, Leah.
Thank you, Rose.
Yeah.
Thanks, Rose.
Mhm.
So this brings to mind too another thing before we go on to the next slide that I encounter because I get phone calls from the community a lot. There is a misunderstanding about what that durable power of attorney for healthcare or patient advocate designation truly does, because Michigan is one of 3 states that does not have a living will law. And so the preferences for care that people put in their documents, sometimes they think that that means it's a DNR order. If I put in my legal document that I don't want resuscitation, they view that as a DNR order, and it's not. It is guidance to the patient advocate. So that patient advocate designation legal document, what that does is it names the person who can legally speak on your behalf. It tells us what authority that they have. Can they consent for care? Can they withdraw or withhold care? And then it shares in the documents the preferences for that the patient has for the care that they'd like to receive during a time when they cannot make a decision. And that document does not expire. So we have a lot of really, really old documents, like from the early 90s out there. And it's really important that people keep their patient advocate up to date on what their current state of health is, what their current preferences for care are. But the medical team cannot act directly on a preference for care named in or that's included in a patient advocate designation or durable power of attorney. And that might have been part of a misunderstanding too with the case that you shared, Heather, because I've had people get really angry with me when they show me on their document, their patient advocate designation document, look, I didn't want CPR. And I say, you need a medical order for that. This is guidance to your patient advocate. So Michigan's a very unique state. So let's embrace our uniqueness and all make sure that we have our documents. So I also wanted to share some resources just to highlight them again. And these you will find on the website for MDHHS, MyPost. If you want to take a closer look at the law or the administrative rules, if you want to look at the different educational slide decks that we created, those you can just download and go through them. And then we wanted to open it up to Q&A, and I'm actually going to stop sharing my screen because I'd like to see if there's anything in the chat.
There's not.
There's not. Okay.
You're good.
Has anyone currently used the MyPost with any of the community members that they serve? Not getting any. So this is not surprising to me when I look at my health system, less than 20 patients have a MyPost entered into their Epic medical record. We use Epic, just in case. Any other Epic users out there? You can just raise your hand if you want. So it sounds like, okay, we've got, oh, good, we've got an Epic user.
Yep.
It sounds like this group hasn't had a whole lot of experience with the MyPost. What about the out of hospital do not resuscitate order? Is that something that you guys use more often?
Or C.
Right, or C? Okay. Sorry.
Couldn't hear.
Sorry about that. I'm at the hospital. We just had a code. So, what about patient advocate designations or durable power of attorney for healthcare? What's people's comfort level with that? I see a little bit more people nodding their heads, like they're very familiar with that. That's great. Okay. All right. Well, I know that today we shared the MyPost. We shared the recommendations and the concerns around using the MyPost. We'd really like it to be a more usable order for our adults with advanced illness or frailty. And as with any presentation that we make about these recommendations, we encourage people to reach out to their own professional organizations to alert them to this, to see if we can affect change in that way to make it a more usable medical order.
Amy, do you want to show that last slide with contact information, or Aaliyah, are they going to have the slide deck PowerPoint?
We'll share
They
the slide
have
deck
it.
on our
Okay.
website.
Then you
Okay.
And then just to let you know, in the chat, Heather said that they use Meditech.
Yeah. So-
Okay, thank you. Yeah. Oh, hold on. There we go. So Rose and I wanted to share our contact information in case others want to reach out, connect with us with more questions. I know sometimes it takes me a bit to really chew on an idea, and then of course I have a question, amazing question the next day, and I'm like, who do I reach out to? So, but Rose and I are really very passionate about this and committed to serving our community members as best we can, and really appreciate your time today.
Very much so. Yep. Thank you for joining us today. That it's very important that you came, and those of you that might be listening to this later, should you have questions as well, both Amy and I are available.
Thank you so much. This was really a great presentation. I really appreciate it.
Thank
You're welcome.
you.
Yep. Thank you, Rose and Amy, for presenting this afternoon. We so greatly appreciate it. And again, if you have any questions, please feel free to reach out to Rose and Amy or Aaliyah and myself. So thanks again, and have a great afternoon, everybody.
Bye. Seen a MyPost in the communities where you serve.
Even if people just want to raise a hand, and I
Yeah.
can't see any hands raised, but do we have any hands raised?
This is Heather Schrag from